people in the back of the room hear me? Testing. Hi, everybody. Welcome. And early happy Valentine's Week. And thank you so much for taking time out of your very busy schedule to hear such exciting progress going on at Kaiser. About 3 years ago, Stanford's Dr. Arnie Milstein put the topic on the table: why is it that California can't do as well as the best in the world for the #1 disabling condition, which is stroke? It's an issue near and dear to many of our hearts, including mine. My own mother was taken by a stroke when I was 15. And what's so exciting right now is that since that time, we have made amazing scientific progress. The frustration is it isn't very well implemented. So what we're trying to do with the Right Care Initiative is speed the adoption of the scientific progress. And we are going to hear such exciting news today, both from Kaiser and Stanford. And we are going to skip our around-the-room introductions today in the interest of time, because Dr. Klingman, the head of neurology for Northern California Kaiser, has to leave promptly at 1 o'clock. So with that, I'm going to turn it over to our co-chair, Dr. Arevalo, to introduce Dr. Klingman.
Thank you, and welcome to 2016. We appreciate this being the first meeting of 2016 as this group. We actually had a smaller meeting of medical directors and QI directors last month, and you'll see that we're changing our agenda slightly going forward, because starting in March, the medical directors will be joining a group of data sharing discussion starting at 11:45. So we'll start this meeting at 12:30 starting in March, and we hope that all of you can continue to be with us. We'll end it at 2, and again, it'll be very focused and very quick to get all of the information out there and to get your engagement, because as you know, part of what we'd like to do with these meetings is really get engagement of the community and not just have presentations, which I think are very, very valuable, but it's really around the opportunity to try to get your thoughts about how we can implement the things that you learn. Like, for example, today we're really excited to hear about the stroke efforts that Kaiser in Northern California is doing, and we hope that you can take much of these learnings and apply them to your situation and your groups and your institutions. So without further ado, we're really excited to present Dr. Jeff Klingman. As Hattie mentioned, he is the head of stroke for Northern California. He is a USC and Stanford graduate and has been with Kaiser now since 1989 in the program here in Northern California, Walnut Creek and Antioch. He also not only is he active within Kaiser, but he's also the president of the medical society locally in Contra Costa County, and also has numerous other leadership roles, and has really done a tremendous job with leading the guideline development for Kaiser in stroke, which all of us are very, very interested in. So today we're going to hear about this program and about the efforts that Kaiser is doing to do so well at addressing stroke prevention in his community. So, Dr. Clemens.
Thanks. So I'm actually, you guys get to be the first for the public unveiling of the Stroke Express program. We're the first people on the train, I guess you could say. So let's see. All right, so here's what's happened. Anybody here that was at the International Stroke Conference last year? So it was an interesting time. In the past, if you have a large vessel occlusion, it wasn't really clear what to do about it. We all know about TPA for stroke, but until just really last year, there really wasn't a lot of evidence around the role of endovascular treatment. People thought that it worked, there was a lot of theory around it working, but the previous year at the International Stroke Conference, there were a bunch of different studies showing really no benefit in the way the studies were done in endovascular treatment. And that was very discouraging. There were a lot of device manufacturers with long faces wandering around. And but what happened last year? There are 4 separate studies showing benefit to endovascular clot retrieval in patients with large vessel occlusions. Suddenly the world changed. And in fact, the numbers needed to treat varied anywhere from 3 to 7, which is pretty impressive after a stroke's already occurred, and these are inevitably big strokes. And so this is a big change. Everyone suddenly has to figure out, well, this is all really interesting, but now you have to figure out how you're going to identify the occlusion. You got to find it. And there's a lot of discussion because not every hospital can do endovascular clot retrieval. And so how are you going to get them to the hospital? And perhaps what we should do is send all big strokes to the center that can fish the clot out in case they may have it. And so there's a lot of consternation. I was at UCSF and someone joked, well, now we're all going to have to be endovascular centers. So this is a real question, is what to do about it. Now at the same conference, there was a lot of discussion about getting really fast door-to-needle time, and in fact how the Helsinki model, which has really exemplary times, was able to be transported elsewhere. You know, it's one thing for Helsinki, right? There are a bunch of Lutherans, they always show up early for everything. You can't be surprised if they do things quickly, but they were able to take it down to Melbourne, you know, and kind of sort of my sense is it's a little bit more laid back. Weather's better, more like California. So if they could do it, maybe we can do it. So this is kind of the thought that I had actually as I'm flying back on the airplane saying, well, if we're going to be able to do this, how do we build space for it? And then we sort of got to thinking, how about if we were able to really, really treat fast? How about if we could actually get that TPA going, because all of these patients get treated with TPA first. How about if we get the TPA going and get that infused in 15 minutes? You know, current standard is an hour or so, and you get lots of awards if you're under an hour. And they're trying to move it to 45 minutes. What if we could get that treatment going in 15 to 30 minutes? That'd build you an extra half an hour to be able to identify the large vessel occlusion and get that patient transferred. And that may be a better solution than saying, well, we're going to send all of the clots to the comprehensive center because, frankly, the paramedics can't figure out who's got the clot. I can't figure it out without advanced testing, and it just didn't make any sense. So if you're looking at a system, which is one thing that we can do, what makes sense for the system to get those patients treated? And so that's kind of the genesis of it. So the challenge in the age of endovascular stroke treatment would be you should get IV TPA as fast as you can. You want to rapidly screen for large vessel occlusions, and you want to rapidly retrieve those clots. So the field-based diversion has certainly been discussed. In fact, there's a lot of people advocating for it and saying, well, there's got to be some scale that paramedics could use to determine which patients would benefit from that. One that's been proposed is Los Angeles Motor Scale, if people haven't seen that, or some other kind of paramedic chosen diversion. And the problem with it is it's really not been tested. It's been postulated that studies that claimed a lot of large vessel occlusion based on high LAM score really hasn't been replicated. Nobody's ever looked at whether this system might work. We know paramedics over triage. It's not a bad thing. We'd rather that they would over triage. I'd rather that they try to do that rather than be under triaging, but it's just a fact of life. And we already know that most patients many more patients get endovascular, get TPA than get endovascular treatment. And there's been various numbers tossed around, but in the Mr. Clean study, which was a pretty inclusive study published in Holland, they found that about 20% of people ended up with a large vessel occlusion. So, and there were other studies showing a similar number. So 80% of people are not going to need that kind of treatment. So if you look at it, a lot more patients are going to be disadvantaged, i.e. driven past the closer center, than helped by any diversion strategy based on the fact that there's not a lot of data. The 87% comes from a study that was presented, I haven't seen it published yet at the conference, saying that using LAMS-based diversion, I think they said 1 in 11 patients were benefited or something like that. It was around that point. And the 96% is if you said, well, you know, you start to say that about 20% of people that the paramedics bring in end up treated, or even if it's 40% and 20% of that, just do the math, and you'll end up with a relatively small number. So that was the idea. So here's the thought. What about, as I said earlier, what if you could really treat with TPA super fast, really quickly get a CT angiogram, and really quickly transfer? Because if you could do that, why would you ever go to divert to a comprehensive center if you can do it just as fast as you could going through the door of the comprehensive center? So that's kind of the genesis of this. If we can do this, then we don't have to worry about paramedics trying to figure out. We get them to a place that's got stroke neurologists that can get them treated quickly, identify quickly, and feed them appropriately to your endovascular center. So that was the idea behind it. So I'm sure everybody here knows about Kaiser, but just sort of a reminder for anyone who's not quite as familiar, we're big. 3.8 million members at this point, so that's a huge group. But unlike places like Helsinki, where there's 3 million people in one city, we're spread out over 17,000 square miles. We have 21 medical centers, so we're not giant hospitals. We tend to be pretty small. They range in size from under 100 beds to about 300, but we're not dealing with 1,200 bed hospitals here. And so this is kind of the reality of it. We got a lot of docs. There's 8,000, more than 8,000 physicians. There's 75 neurologists, which is not enough, but I think, but I can't convince anybody else of that. We've managed to get the job done, but there's thousands of emergency room docs and RNs, so if you're trying to do something like this, how are you going to scale that, right? Are you going to train every emergency room doctor? How do you get the neurologist there? That's kind of the scope of the thing. It's an enormous geography problem. Now, right now, we don't do badly. Right now being when 6 months ago. When this all started, we were doing very well. Every Kaiser hospital in Northern California is primary stroke certified, and Redwood City recently got comprehensive stroke certified, and Sacramento is the other place working on comprehensive. But every single facility is stroke certified. But what was interesting is every single hospital had its own separate stroke alert process. And that's partially because, you get certified at an individual hospital, but we left it to the hospitals to develop their process. The door-to-needle time is variable, but if you look across the entire enterprise, it was about 60% of people treated in 60 minutes, which is enough to get you a lot of kudos. All those little blue things and red things are different awards for stroke care. You get, I can't remember all the list of them now. Somebody here may know it, but I think you get, there's target stroke, and there's, target stroke elite, and then there's this and that. We're going to keep having to add adjectives to the thing. But we did very well, but it wasn't good enough, to my mind, to say, what can you do to get to the best in the world? Because there's a lot of variability by doctors, by centers, and so on. And so we sort of asked the question, what would it take to get to best in the world? So what would it take to get 15 to 20 minute door-to-needle times?
15 to 20 minutes.
15 to 20 minutes, that was the target. At this point, the fastest we've done is 7 minutes. Get very rapid CT angiogram, because that's part of it. If you don't do the CT angiogram, you're not going to be able to do it. What would it take to treat, evaluate, and get them transferred in 45 minutes, which is faster than most places can deliver TPA? And so that was the overarching goal, was to do it as fast as we could. So this is the export of the Helsinki model to Melbourne. And what you can see is that the door-to-needle time has dropped steadily since about 2004 when they implemented the program, and the number of cases treated quickly has gone up. And they are routinely delivering TPA in the 15 to 30 minute range. So that's what's possible with the export of the process. So I've been, I guess the right word is junkie. I've been watching people present what's really fast for door-to-needle for a while. And it seems to me there's some common themes. And one of them, and actually they'll tell you this from the work in Helsinki, is getting the stroke neurologist involved early is absolutely critical to doing this quickly. In Helsinki, when there's no stroke neurologist on, their times go back up to 45 to 60 minutes. So their after-hours time goes way up. So you need that stroke neurologist involved early. And the reason is it's a clinical evaluation. It's not just based on a CAT scan. It's not based on an EKG. It's a clinical evaluation by somebody that really knows stroke. The other thing that's clear is you can't go into an ER room. If you go into an ER room, what happens is they get plugged into the monitor, they get plugged into the wall, they get plugged into the oxygen. It's a minimum of 15 minutes of time wasted, so you can't go into the room. You can go in just long enough, only if it means getting out of the cold breeze coming from the ambulance bed. But you got to get it there. You got to get the TPA ordered before the CT. So this is a C change. And the reason you have to do it is the longest time on here is mixing the TPA. We're still mixing them all in the pharmacy because of safety concerns. It takes 10 minutes to mix the drug. If it takes 10 minutes to mix the drug and you don't mix the drug till after the CT scan, there is no way you're going to be able to get to those kind of numbers. So what we do is we order it based on the clinical evaluation. If in fact they have a bleed, which doesn't happen very often, we don't give it. But that's kind of that was a big thing. A lot of concerns among nurses around how we can be safe, and the key to safety on this is constant communication. And then the other thing you want to do is you want to get TPA in the scanner, because coming back to the emergency room adds unnecessary time as well. So we have a problem though, which is I already told you, we've got 75 neurologists, we've got 21 medical centers. I can't justify having a stroke neurologist sitting in an emergency room waiting for a stroke that may never come. So we have relatively small volumes at each site, and so what we did as a result is we went for video consultation and completely redesigned the process. So it's all done by video. So when I'm on stroke call, I'm sitting there with multiple computers in front of me. And generally it works pretty well. I did have one day when I had 6 at the same time. I'm not sure exactly how that worked out, but it did. So that's the process. So we got started with this and pretty early on engaged senior leadership and got a huge amount of support. That was critical because that removed a lot of barriers. If I tried to do this with just kind of incrementally, it would be a problem. We also had a very aggressive timeline. Started this discussion in March and said we want to roll this out by the end of the year. And the reason we wanted to roll it out by the end of the year is actually partially political. There were people trying to say we should divert all these people to comprehensive centers, and I thought that was just bad science, and I wanted to get it out and running so we could demonstrate the benefit. We had a multidisciplinary team because this is a team-based sport. And so ED doctors, stroke neurologists, neuroradiologists, because they're critical to this as well, ED nursing, the hospitalists, the CT techs, people from lab, people from pharmacy. The team came together to design the process. And we got a lot of project management support as far as I can tell. The entire Permanente project management team is working for me now. Don't tell anyone. And we did a lot of planning about the new process, and the goal again was roll out by the end of the year. So this is kind of what happened before. The old process was serial, and it's pretty typical. So what you do, the patient comes in, and then they put him in the room, and then the RN sees him, and the RN says, holy smokes, I think it's a stroke, and she would call the ED doc, and the ED doc would come in and say, nope, you're right, it's a stroke. And then they would call a stroke alert. And they would order the CT, and they'd send them down to CT, and they'd get the CT scan done, and then they would read the CT, and they read it really fast, and they'd send them back to the emergency room, and at some point in there they'd call the neurologist, and the neurologist would sort of talk to the ED doc and say, yes, it sounds like a candidate, and the doc would then order TPA, and then we'd wait for the labs to come back, right? And then we would push the TPA, and then what happened is you get the TPA going, then you go back down to CT, you get the CT angiogram, often after the TPA is concluded, and then we would result the CTA. There wasn't a real rush to get that resulted, and then we'd call the ambulance. So this is a long process. That's hours. That's a couple hours there minimum. It just can't be done any faster. So the new process is way more parallel. We call the stroke alert as soon as there's a question. So we're calling stroke alerts by the ambulance drivers. They say, we're coming in with a stroke, and I get a call on an 800 number, and I pop onto the video and I greet the patient in the ambulance bed. Or if it's a nurse, they call the stroke alert and the same thing. The key is to call a stroke neurologist early so we greet them in the ambulance bay. Again, on for 21 hospitals. Patient comes in and we swarm on them. So you've got actually one RN on one arm, one RN on the other arm, an ED tech at the base. We've got the ED doc there. Everybody's there. They actually have their place to stand. It's a pretty complex dance that's done in order to get everything done. And we're examining them by video at the same time. The goal is to make a decision, have 2 lines in, and roll the CT within 5 minutes. If we decide, we do the discussion with the patient of the TPA. Sometimes we have to try to reach the family. If we can't do it, we'll order it based on implied consent, and there's some studies about that. If it's an appropriate candidate, although we do try to get consent on this, and we order the CT angiogram at the same time. The other thing we do is we call the ambulance. We call the ambulance now. We say, okay, we've got a TPA candidate. We're going to put you on alert that we may need a transport to get some ready. And in fact, in the largest strokes, we'll actually pre-order it. So if it's a big stroke where we think there's a high likelihood of endovascular, we're ordering a CT rig. And then they go down and we've ordered
I'm sorry, I didn't quite understand that. So could you just repeat that a little bit more?
So what happens is when we first order the TPA, we also let the ambulance know that we've got a possible stroke alert transfer. About 20%.
So about 20% transfer to a higher center.
That's correct.
Okay, that's.
Unless you happen to be at Redwood City or Sacramento, in which case I always have to remind myself, oh wait, I don't have to call the ambulance. That's actually a challenge, is for the stroke neurologist to have their head in the game and know not to tell them to order the thing, right? Because I'll get the call from the place and they say, I've got a stroke alert. I'm like, I need a little bit more. Can you tell me which facility? And then if it's a big enough stroke, we're actually telling them to come on down, not just advise them, but tell them to come. If they have to turn around, it's a small price to pay, because you don't want to wait an hour for the ambulance to get there, or half an hour. So we took them to CT. So the TPA is being prepared as they're rolling down the CT and getting the CT done. And what happens is if the TPA is in the control room, by the time the CT is done and resulted, and I can see the films, but usually radiology can see them faster, and we have that discussion. Because they roll the cart down to the control room, we stand there and talk to the team right there. And a lot of times you can talk to the radiologist through the computer. And if the TPA is in the control room, if the pharmacy, really work fast, by the time the CT is done, we push TPA right there. If it's not in the control room, we don't wait. We go straight to the CT angiogram, because acquisition only takes 4 minutes, and then do the TPA right after that. And then we do the CT angiogram after, if it wasn't already done, and then it gets read very fast by the neuroradiologists as well. They're really reading off of source images and usually not waiting for the reconstructions and the MIPS, although it's interesting, everybody stepped up their game and the CT techs are able to do the reconstructions a lot faster than they ever used to. It's really interesting. Ambulance comes, we're working on more rapid packaging. One of the things we disclosed is it takes a while to get the person ready to get transported. So there's currently work going on to really expedite the process for transfer so that the sign out is done before they get here. Because again, it's all about trying to get people out the door quickly. We don't have a lot of work to do, at least right now, around our comprehensive centers, because currently the Redwood City site, where we send a lot of patients, their door-to-groin time is only 17 minutes. And so if we can get them there, we've got a lot of ability. So this is kind of what it looks like. We start stuff at the beginning. We've asked the paramedics to work with us to give us as much information as they are willing to or can, because then I can open the chart, get started, review the patient first. They'll get a glucose. We try to get 2 lines because 2 lines really helps, one for TPA, one for CT angiogram. It's another thing, if you only have 1 line, you have to do the CTA before the TPA. I should say CT angiogram. We had some problems where somebody said CTA and the nurses heard TPA. You have to be careful about your speech and discussion also. And so the lab's drawn. We don't usually wait for labs. That's another thing that's of interest. The data suggests that you can safely do a CT angiogram unless you know they have kidney issues. Why wait for the creatinine if the data says in 500 patients you don't cause problems? So that's one thing. The data suggests that you can safely use TPA without waiting for an INR or platelets unless there's some suspicion. So we do that kind of question. If we have a non-member, which we get a lot of, and we don't have their drugs, that would be an exception where we may wait for the INR. Wait for see if they have. Otherwise, we generally proceed without labs. That was a sort of an aha. And everything gets ordered before. So in theory, as we work this out, we should be able to do go, no go. And we do that as a constant back and forth discussion. It's very verbal. There's a lot of calling out in this, just like in a code. We should be able to start TPA in the 15 to 20 minute range if everything goes well. And we should be able to get out the door within 45 minutes. So we can take a look and see if the theory matches the reality. So the key thing, stroke neurologist is involved early in the workflow. We go direct to the CTs. We don't stop in the ER room, other than, for example, in Walnut Creek, where I work a lot, they've got a little spot right in the ambulance bay. Other places have found other places to go. Almost everybody gets a CT angiogram. We're not really being discriminatory. We're kind of going for the Mr. Clean model, which is sort of everybody. We're not waiting for CT perfusion. Other people have looked at it. I wanted to cast a wide net rather than a restricted net. And then we go for rapid transport. And again, we're ordering the ambulance, or at least alerting the ambulance before we need them, so that by the time we need them, they've already are on their way over. It's the neurology group. That's been an interesting one, is to get the neurologists involved. So we've got what's called the hub, known as the stroke force. Took a little bit to come up with force. We go for, lightsabers and all. Stands for Fast Operating Cerebrovascular Experts, huh? And you're wondering how many beers it took to come up with that. So it's a small core group of stroke specialists. Right now I've got 9 of them. I'm trying to beef it up because everybody on the group still has day jobs, so they're getting a little burned out. So we're in the process of beefing that up and hiring us.
How do you transmit the stroke alert when you call it?
So the stroke alert comes on an 800 number. It goes through something called Ring Central, and so this is one of those things where you fill in the time, you fill in who's the shift and where it gets transferred. So the computer telephony is what sets the thing up. So when it rings, it says stroke force, and I pick it up. On Sunday, Super Bowl Sunday, one of my docs that was working the hub calls me and says, my internet went down, I can't get it back up. I need to drive into the office. It's 30 minutes to the office. I said, I'm with my mom. She just had a stroke. I can't do it. But I was only 5 minutes from the office. So I could drive to the office, cover her till she got up. It's amazing the things that come up. But in any case, no calls during that time. So what happens is I was able to, though, shift it on the computer to me until she came and then shift it back. And so that's the way it works. We do the exam by video. In my area, we've been doing it by video for a while, and it works really well. It's a very standardized exam. You can teach people, other folks how to do it. We use the RN and sometimes the ED doc. The ED doc is really, very helpful as well. It's sort of a fluid thing, and we run this from 7 a.m. to midnight, 7 days a week. Every time I say this, people say, well, how come you don't run a 24/7? And there's two reasons for that. So one is we don't treat wake-up strokes, and most people are sleeping between midnight and 7, so the volume is a lot lower overnight. I can't really justify paying somebody if the volume is that low. The second thing is I can't staff it. If I have to get people to stay up all night with the group that I've got, unless I've got an apartment in Paris to offer, I'm just not thinking that I'm maybe able to staff it. I'm voting for the Paris apartment, but I don't know that we have the volume yet. The neurologist orders the TPA. I think that's important. That's important because there is still a lot of concern among ED docs about TPA. They don't believe in it. There's some of their professional societies don't believe in it. It's a big kind of issue. And you know, frankly, I don't blame them. It's a high-risk kind of thing. It's a clinical evaluation. They don't do this all the time. Remember, there's thousands of them. You may order TPA once a year. It's really better to have the neurologist involved to order it. There's always a discussion. I'm going to order TPA, Dr. Smith. Do you agree? And we have a discussion. I want that team evaluation. But the neurologist ordering it has been, I think, a big success. They like it. We like it. And typically, my stroke neurologist on shift is doing at least 2 TPAs a day, not 1 a year. So it's kind of like the pit crew idea when they roll in. The first step is the pit crew. So they come in and they get jumped on. On the left is the pit crew. On the right is one of our mock strokes where you can see the team around the patient taking a look at them and evaluating. And in real life, it's almost hard to get the exam in because they're usually getting IVs poked in their arms at the time. And so you really need to have that team. There's the central 800 number. We can pop onto this telepresence unit. We use a Cisco device. There's others out there, but the key is it's got really good sound and video, and you can click very quickly. So it's one click and you're on. You can't be screwing around with connection problems. The ED doc is supposed to look at everything other than the stroke, right? These are all patients that have medical issues. Somebody's got to look at that while I'm looking at the stroke. We want 2 lines if we can get them. We can live with 1. We order blood sugar testing. We only wait on the this can be point of care. We only wait on the anticoagulation if there's a need, as I mentioned. We do discuss at this point TPA risk benefits, alternatives, and so on. And at that point, order the TPA. The call on and off the stroke alert is based on that clinical assessment. And frequently, we will at that point call off the alert. And the reason we'll call it off is find out the last known well was 2 days ago. Or it's a stroke mimic. Or there's not a disabling stroke. And so that is it's not an easy. It turns out this is not an easy. Nobody's ever as straightforward as the ones we practice on. We did find one of the things that was worthwhile is a checklist before we head downstairs. So we actually have a little team huddle checklist before we go to make sure we didn't forget anything. That was something we learned about mock number 2, that it really was helpful. Step 2 is go to the CT directly. In some cases, the CT is very close. It's in the emergency room. In other cases, it's over the hills and far away. You have to go down the elevator, down the hallway, and so on. But in any case, at that point, we're not losing time because the TPA is getting mixed. CTA is completed directly after the CT if there's one line or if it's not available, or right after we start the TPA push if we have 2 lines and it shows up in the control room. And the TPA is given in the scanner if there's no contraindication, so we don't give it until we see the CT. That's one of the stops. It's not